Free to
Okay,
take it away.
great. Thank you. Thank you everybody for coming tonight. I know it is the most gorgeous day of all time outside, so I greatly appreciate you spending your next 57 and a half minutes with me. I will be extremely mindful of all of that to be before we get started. But yeah, thank you for coming. I think I'm seeing some common names coming to these things, which is greatly appreciated. I think the overall idea is that we're just getting the word out that this is something that's being done for the first time. So again, thanking everybody involved. And of course, the members of the MRC is extremely important too. Just for a little bit of context, again, to repeat, I am an MRC volunteer and leader in New Jersey. And we're hoping to start echoing this in other places. So it's appreciated that you're here. The surveys, be as honest as you can. Those comments are really helpful. If you enjoy the context, you think there's something else that we're missing, you have an idea to consolidate things, your ideas are as valuable as mine, if not more so. So please feel free to tell us anything that you want to. All right. So moving right in, we're going to be talking about Down syndrome tonight. With any of these overall arching subject matters, an hour is never enough. All right. We could do an entire 16-week series on these things. So I hope you're understanding the reasoning for the overarching discussions, and that a lot of the background and context that I'm giving you is, again, me putting myself in your shoes of somebody with fill in the blank is in my vaccine clinic, they're at my shelter building for whatever reason, health fair. This is going to give you just a little bit more knowledge to be that much better of a support. When you do exhibit the things that I'll talk about at the end, you will literally see somebody's light just go out there. Like they'll be so much happier because they get it that you get it, and showing up is a big deal. So again, for the fourth time, thank you for being here. Down syndrome is one of those diagnoses that we get a definitive, this is Down syndrome diagnosis. We talked about autism in here. Autism doesn't have a blood test. Bipolar doesn't have a blood test. Most mental health, anything to do with mental health, rarely has a diagnosable blood test. Even more rare, we can diagnose this to some degree before birth. And because of all of what I've just said, there's a lot of buildup and discussion in the developmental period. And previously, I've said developmental period is basically anything under the age of 21. When I'm talking about it tonight, I'm really talking about conception to the age of 5. The reason being is I'm going to go through all of this and show you that there are some very specific areas to pay attention to when working with people. Now, again, I don't know why you're here other than you're an MRC volunteer, but I would bet if you're somebody that's been showing up, you have an interest in developmental disabilities, probably for a professional or personal reason, or both. Or you're just interested for whatever that reason is. You could be somebody's information go-to. And you're going to hear about some stuff tonight that you'll be like, all right, this doesn't really apply to people that are showing up at my shelters, but this will provide you with some tools that will allow you to be a better resource for showing up tonight. One of those things is right off the bat, and I'm going to talk about. Again, I could do an entire day on just developmental milestones, but focusing on just what's on the screen here, looking at the left side, the Centers for Disease Control and Prevention had put out every couple of years these developmental milestones that physicians, pediatricians, developmental pediatricians, there's a lot of different types that work in this area, look at each of these stages. If you are a parent or a grandparent, or you've been somebody that's been in the room with a pediatrician and a young child, there are very specific screening questions that they will ask the parent, the caregiver, whomever, and they'll do an observation of the infant if the child is not verbalizing yet or is not verbalizing, period. The reason being is there is so much that can go on in child development. Looking at this, I saw this on the web, and this isn't like the most clinically sound thing, but I wanted you to get a sense of it being like and I'm not trying to make a comparison between developmental psychology and science versus a board game. But every toss of the dice, everything that you do in a board game has potential rewards and consequences. So when I saw this graphic, I really connected with it and thought it was really helpful to display that. Every bend, everything that you have to do, there's another potential challenge that you have to overcome from the moment you're born until it's over. Right. And these are those milestones. I'm not going to go through all of these. I'm going to go back to the previous slide in a moment, but I just wanted you to see visually, to see from the moment we're born till we're through that developmental period, every next stage has scaffolding, like when we're building a skyscraper in Philadelphia, right? We start off with what looks almost like a skeleton, and it builds, and then it builds on top of that and on top of that. Human development is very similar in that development continues throughout our lifetime. We have degenerational changes when we hit a certain level, but that'll be somebody else's conversation, not mine. So when the CDC puts this stuff out, and the reason why I'm telling you this is that these milestones are akin to providing screenings and potentially leading to services and diagnoses during this really pivotal period. Time is of the essence. So when we're finding out that somebody may have a developmental disability, doesn't matter what it is, or even go further, a disability, right? It needs to be addressed sooner than later, because by the time your body starts to mature in any specific area, the time could be too late. I'll give you a personal example. I was born with a very severe crossed eye. My right eye is significantly less able to do anything compared to my left, muscularly specific. It just kind of can go all over the place. I was told I was a baby. My parents were told at a very young age, this is a surgical fix. If you don't fix this by the time he's 3 or 4, the ship is sailing away, right? So that's an example of, we need to get on this stuff. The issue with developmental disabilities, with the exception of Downs, is that we don't always know what we're dealing with until we start to see some of these developmental milestones getting missed. The advantage of genetic testing, and then there are some very obvious facial structures and things that we'll look at tonight that make it very obvious, and then you can start dealing with whatever those needs may be right off the bat, right? But the CDC splits these up into 4 main categories, and you can obviously see them here. So you might be asking yourself, social emotional, what is a 2-month-old going to do, or a 4-month, a 6-month, to express social and emotional milestones? You might be surprised when we look at these very young stages. We're looking at very concrete things that to look for. Is the baby looking in the direction of where sound is coming from, right? Because babies at this age, at the really young ages, they're not seeing in vivid colors yet. They're not able to really focus very well on a caregiver's face. There is an app out there. There's multiple apps out there that actually, if you're interested in this kind of thing, will let you use your phone's camera, and you can set the month or the year that the baby is supposed to be, and you will see what the world looks like through their eyes. It's really cool. I wish I knew the name of it. This is what happens when you spontaneously think of things during trainings. But nonetheless, there are specific aspects of these different areas. Language and communication. A 2-month-old is obviously not going to be speaking, nor is a 6-month-old. But communication is language for this age. So is the baby a lot quieter than normal? Or, to a new parent, normal is a meaningless word. But this is why screenings exist in a pediatrician's office, so that there is a standardized approach to these things. Because, as a new parent, I might be way more neurotic, scared than the next person. Or I could be so lax that I start missing things, and now we're 4 years old and we have a problem, right? It's not everybody makes every appointment for all sorts of different reasons, especially when we're talking about people with developmental disabilities. Cognition and thinking, this is one of those areas that you may actually not see a very large difference between somebody with Down syndrome and somebody that doesn't, until we are a little bit more into school age. And that's when you'll see the separation of the pack as kids start to figure out, pre-K, kindergarten, first grade, we're just learning the fundamentals of how to be a student. When we start learning how to do beyond like 1 + 1 is 2, when we start learning that A, B, C's turn into sentences and words and things like that, so second, third grade is when you start to see the general population kind of pull away in that area of cognition, thinking, and problem solving, which we'll come back to later when we're talking about people you're working with. And then physical movement as well. You shouldn't be surprised if you've heard any of my talks to this point about what I'm about to say. Down syndrome is not an exception. Unfortunately, there are a lot of physical and mental health comorbidities that exist that are exponentially more so than the general population. So physical movement is something that's very important to pay attention to, especially in infants as they're crawling, they're trying to walk, as they're scooching across couches and whatever the environment allows them to do. But they're important milestones to pay attention to, right? And as time moves on, the time periods get farther and farther apart because we're maturating at a larger level, but it takes more time. When we get to the 5-year-old, some of these are good. So I'll read them to you. Writes some letters in their own name, hops on a single foot. So you can see there's a balance here between cognition, memory, physicality, following rules, or taking turns when playing games with other children. A lot of times people look at kids that might be on a playground and they're not sharing, or they're not following the rules, and they might think the parents or whatever, or the teacher's not doing their job, or the kid is just not a nice kid. A lot of times you'd be surprised that there might be something else going on with that person, and it could literally be a cognitive issue where they're having difficulty understanding the concept of sharing, simply because if you really think about what sharing is, you're expected to give something of your own to somebody else, and we don't really do that as adults. So this is something my wife and I have talked about as we were, raising our kids and talking about the concept of sharing. And just thinking about this, like, oh, we're teaching our children how to socialize, how to be good humans, holding the door for people, all those nice things, but also that. And the concept of sharing is sometimes lost on adults as well. So it's one of those intangible concepts that when you're trying to teach to a 5-year-old, with or without Downs, that's a tough thing to put out there. So severity of not meeting those milestones is also an important variable to think about. I mentioned apps earlier. If you do anything tonight, take this down. This is, if you just literally put in CDC milestones in the app store, it's free. I can't convince you if you, have things against the CDC, but this has been an app that's been around a long time, and I can't say enough good things about it. For you as a person living in a society, you might be somebody's parent. Let's say you have no direct connections to anybody in your family with Down syndrome or professionally. You know anybody that's possibly going to be giving birth, is pregnant, might be getting pregnant, for any other reason, you are a resource to them. This is an app most people don't know about, most doctors aren't aware of, and they're not telling the people that they're caring for, their patients. And I think it's a really good thing to talk about with public health, being that this is part of a public health department. This will let you set up in your phone a name, or whatever name you want to put, but basically you put in where or when you think conception happened, and it'll help you with that as well. Or if you have a due date or whatever, it helps you work through that and figure that out. And then it will tell you all the different milestones, or the date of birth rather, and it will tell you all the milestones that should be getting reached at certain points. And it will actually send you reminders, and it's interactive. It's not just a yes, no. It'll tell you if things are being met, if they're not, what might be an issue, and when to really call a pediatrician for a screening. A monitoring is this. This is you as a caregiver or whomever. If you're an auntie, if you're a grandparent, you're an uncle, a friend, whatever it is, you are in the public health world because you are listening to my voice. So you're an MRC volunteer. This is a really cool app that will point out a lot of different things that most people are never going to think about. And it can really help with these super early stages. This is really where a lot of things get missed. because it is so hard to figure some of these things out, especially when you're a new parent. You don't know what these sounds are. I remember my daughters making some very bizarro sounds, and one of them did have an issue that she grew out of. I can't even pronounce it, laryngomasia or something like that. It was something in her voice box wasn't mature. There's so many things that go into a perfect developed baby through gestation. So this is like this is like having somebody in your pocket. So get that down, take it, spread it. It's great for even people like me, quote unquote professionals. I'm not a pediatrician. I'm not a developmental pediatrician. And people will ask me all the time, hey, my 4-year-old is doing this. My 5-year-old is doing that. I let them know about this. I give them an opinion, but this is a really, really helpful thing. So helpful for everyone. Satori, this is something you might even want to take back to whomever, because it really is such a great resource. Commercial is now over. Thank you for listening through that. So let's talk about Down syndrome as a diagnosis, right? We've talked about autism and a few other diagnoses in here, and they're kind of in the intangible aspect. We can't, again, go back to the original conversation about a blood test. There are no blood tests for those things. For this, there is. There are multiple ways of getting a diagnosis. But what is the diagnosis itself? A set of cognitive and physical symptoms that result from having an extra, full, or partial chromosome. Okay. Most of these abnormalities will cause mild to moderate ID. It is possible to have a diagnosis of Down syndrome and not have an intellectual disability in the same respect and logic that autism follows, but at a significantly less amount. There are a lot more people with Downs and intellectual disability than there are people with Downs that don't have intellectual disability. They're also at risk for a lot of other health conditions, which we will be going over very shortly. And, for those of you that don't know a lot about chromosomes, it's been a decade or two since bio. Same for me. Just going to read this to you as it was written so that I understand it just as equally as you do. These are the parts of our microbiology that carry genes to the body and tell the body what to do and how to form. It's the blueprint for building that building, like I talked about earlier. It's the scaffolding. It's literally the directions for our stem cells, which are cells that can turn into almost anything in our bodies. When those stem cells are ready, they're mature to become something else. The DNA inside these chromosomes tells them specifically what to do. You're going to be an eyeball cell that looks at color. You're going to be a renal cell that's going to be inside somebody's kidney. Everything has a specific purpose. Most cells in the human body, without getting into advanced bio, have 23 pairs of these chromosomes. When we have a diagnosis of Down syndrome, somebody has either a full extra or a partial copy, right? So there's different types of ways of diagnosing this, but you'll see sometimes this 47XX plus 21 written this way. Either way, it's Down syndrome. Sometimes you'll hear trisomy 21. That means 3 on the 21st chromosome. You might even now understand, if you didn't before, the meaning behind World Down Syndrome Awareness Day. It's on March 21st, 3/21, right? So there's a lot there. Most people do not realize, however, that I'm going to come back to this, that there are different types of Down syndrome. But before we get there, I want to show you how we are at risk and how we get to that actual point of getting a diagnosis, potentially even before the baby is born, or a rule out diagnosis. In other words, we know this is coming unless something is drastically wrong in our predictions and testing. So prevalence, just in general, how many births are there that are having people with Down syndrome? It's not a very large amount in the country. But if you look and take the time real quick to look at the different maternal age groups, it's not necessarily the prevalence of Down syndrome, but the prevalence and the relationship of that prevalence with maternal age. In other words, how old is that mom when she becomes pregnant with this baby? So now we have to look at that because it increases over time, right? And this is an important factor, right? Under this age of 20, it's very low. And you could see something happens, right? If you remember algebra in math class, when we start seeing exponential growth, it's a parabola. It does that. And that's what we're seeing once we hit around age 30. I believe officially the age for what's considered to be an at-risk pregnancy starts at the age of 35 in referencing Down syndrome, just when we start seeing a significantly higher amount of births with Down syndrome resulting from this higher maternal age. There's a lot of other factors that could be going on in it, but that's some of the theory. The biggest thing that we're looking at here is obviously this truly doubling or tripling amount of people that are giving birth over the age of 40, right? Without any direct comparisons, this is hard to see anything other than there's a correlation between age increasing and an increasing amount of Down syndrome. Looking more specifically at the percentage breakdowns, because the specific amount in the population is going to change over time. But the amount that's specifically here with the population comparisons is important to look at, because over time, these age groups are changing. And just recently, there was a new study that showed, for the first time in American history, at least, the group of youngest mothers has been surpassed by the group of oldest mothers. So in other words, there's a larger group of women 40 and up having children versus the youngest group, 15 to 19, that were researched on. You might be saying, why am I not talking about men or anything of that nature? You know, there is some correlational research out there that does talk about older men, but the basic biology behind the emphasis on female versus male age at the time of gestation is because women are born with eggs for their lifetime at birth. Men produce sperm throughout the time. So when somebody is born, that egg is going to be 40 years old when it is being fertilized at that point. So the theory and understanding behind that is that it's older, degenerative things happen over time, and that's what's going on behind all of this. About 6 million people in the country, to just give you a flat number, have Down syndrome. About 330 million, so we're less than 1%. However, we are seeing an increase in this older group of people having children, as well as the second oldest group that starts halfway with that higher risk level. So it's possible we're going to see an increase in that. You know, one of the reasons why we're seeing, you know, I'm going to ask you, we haven't done this much. I'm going to ask the audience, you could chat, you can come off mute. Anyone have any idea why the groups are getting older with having children? Like, why would there be an increase in that group size of people 40 and above having children? Anybody want to take a shot at it before I fill in the blanks? All right, well, I'll give you the answer. A couple of different reasons. One, we are a lot better. Oh, we got somebody in the chat. What do we got here? Economics, yes. So economic is the go-to idea. You know, my wife was in her upper 30s when we had our children, and we told right off the bat, you're at elevated risk. I think at the time they may have even used the word geriatric pregnancy. But in order to get into the career that my wife was trying to do, she required a doctorate and finished it in her mid 30s. And, you know, with that, things get delayed. And that is a big thing, especially, you know, women are getting higher educations at great rates now, equal to or better than men. We're pushing for that, the whole STEM, you know, pushing girls into careers like for STEM, science, technology, you know, things of that nature is a big piece of that pie. Absolutely dead on correct. The other aspect is we're getting better at this stuff, the testing, the ability to pivot when we see issues that may or may not be there, and just getting better at pre and postnatal care. Like, some of the things we used to worry about are not even out there these days. Down syndrome is not one of those things, but over time, perhaps we'll get there. You know, things with genetic abnormalities and such, do tend to get taken advantage of with that technology. So hopefully that's something that we'll see more of, in the future. So there are a few different ways of screening for this stuff. There's screening and then there's diagnostic. Screening is what is just drawing blood, an ultrasound, lesser invasive tests. On the other side, the diagnostic testing, amniocentesis and CVS, which is chorionic villus sampling. Both of those, amnio and CVS, require some type of intervention. And what happens in there specifically isn't the most important thing of this talk, but what is that there's an intervention. The chorionic villus is going into and taking a sampling from the placenta. Amnio is also similar. So there is some risk to both the fetus and to the mom. On the other side, back with screening, we actually had to do some of this. We had a couple of situations that were factoring us to high risk pregnancy. My wife has a blood clotting disorder, so she is on blood thinning medications for life, which makes becoming pregnant something you have to plan. It can't just be spontaneous, because the medication she takes would almost absolutely result in a bad outcome. Her age, and there was also, you do genetic testing, and one of the genetic tests that came up was she was a carrier for a very specific type of genetic abnormality. And so I had to get tested. Everything is high risk, super high risk at this point. And they do an ultrasound where they check, it's called nuchal translucency. They take, and this is somewhat newer, for any of you that haven't been, in the OBGYN's office in the last 20, 30 years. It literally measures the back of the neck of the fetus. So they did this by ultrasound, and I couldn't tell you the specific measurements, but basically that and the nasal bone, which I think is on the newer side of things, the thickness will tell you whether there's an increased risk that will make you want to do these things or nothing at all. So we went through all these things, and it's an experience, and it makes you think about a lot of things and what you were potentially looking at. This allows people to prepare. This allows people to have just a better idea as to what the plan is going to be for them. And then there are subtypes, like I alluded to earlier. There are classic stereotypical looks to a person with Down syndrome. And I don't even like saying the word stereotype when I'm talking about any type of person, let alone a person with a disability like this. But because there's a genetic component to this stuff is, I don't even want to call it a stereotype. This is what you could expect to see. Brachycephaly is basically talking about the growth of the head. You see there's almost like I think the wording has been almond shaped to it, where it's kind of more convex on the top and comes down like this. They'll see some folding of the ear, more of a flat facial profile. The tongue sometimes is protruding because the physical tongue is overgrown. Inside parts of the eye, called the epicanthal fold, also will have a specific look to it, again, making that almond shape. And there's that redundant skin, which goes back to the nuchal test from the ultrasound. That's what you're looking at prenatally. All of these things exist in a person with quote unquote Down syndrome or trisomy 21. You may have never heard of or even realized that there are 3 types of Down syndrome that are out there. Trisomy 21 and translocation. Again, this is not stuff that is going to be helpful in the long run, but just so that you know it exists, right? There's 2 different types of trisomy 21 or Down syndrome that are very similar in their appearance and their symptomology. There's also another type called mosaic. It's a combination of normal cells that are kind of peppered in with the additional 3rd cell. Because of that, you essentially get a mosaic of this. So you're not getting the full-blown symptomology of what this looks like. So if you've ever seen somebody in the world, in your interactions, walking around, somebody that you know, if you've ever seen somebody that has some features, but you're like, they look like this somebody with Downs, but not quite. You're seeing more than likely somebody with mosaicism. It's a combination of those things. It's about 1% of all patients with Down syndrome. So it's very, very rare. I think I've maybe seen 2 or 3 people in my time, working directly with folks. So again, it's something for you to think about if you see somebody at your shelter, at your clinics or whatever, or in your own life. These are things to kind of just look out for. Doesn't mean you need to treat them completely differently. I will say that the severity of mosaic Down syndrome might be along the lines that what you might be thinking of. It's not as severe. You have that peppering of the mosaic. You've got a little bit of symptomology in one aspect of your body as opposed to others, right? We got 23 chromosomes. So instead of all 23 having abnormalities, maybe 5 or 6 have abnormalities, right? So it's essentially that to a lesser degree. Just making sure I didn't skip over anything. Nope. Okay. So here's where the rubber hits the road for you guys as the audience and people that are trying to support folks that have these comorbidities. There's a lot of them. People with Down syndrome have a very tough uphill battle from day one. There are a lot of different areas that you can see here on the right. This is from a study that's from Penn, and I'll cherry pick a few of these. So obstructive sleep apnea, right? So the inability to get a good night's sleep because your throat essentially is closing at times because either it's thickness or some other structural issues. And having that can really affect your health. It affects your heart, it affects your lungs, it affects your brain, because you're starving yourself of oxygen repeatedly every single night. 50 to 79% of Down syndrome have that. Now, this could be a chicken or the egg because obesity is a very highly prevalent issue among people with Down syndrome as well. Obstructive sleep apnea, a lot of these chronic issues could be a chicken or the egg thing, but the correlation among people with Down syndrome is way higher than the general population. So you've got obstructive sleep apnea, hearing loss, otitis media, really fancy name for an ear infection. But again, going back, the physical structures being different will cause physical chronic problems. So you can imagine there's going to be dental issues, right? Visual issues, hearing issues, just all these other things outside of just what's going on cognitively inside that person's brain. Now, previously, the lifespan for somebody with Down syndrome was 40 was elderly, 40 was geriatric. I don't think I had really met many people over the age of 45 that got to that part of their life. The issue is just because you have one of these things doesn't preclude you from getting another one and another one and another one, right? So neurological dysfunction and seizure disorder, 1 to 13%. It's because of how it's categorized. Thyroid disease, right? Whether that's hypo or hyper thyroidism, 4 to 18%. And this is like 1 out of every 5 or 6 people that you're talking to that have Downs may have this stuff. Whereas you're talking 5%, 10% in the general population. Hip dislocation. Again, we're talking about younger ages. What happens with a lot of people with Down syndrome up until recently with that lifespan is they experience something called accelerated aging. Once you hit a certain age in this life, whether you're listening to me right now and you're in your 20s, your 40s, your 60s, or more, at some point you just get to that, okay, my back hurts today and I didn't do anything, right? You start to experience that. And then, maybe a couple of months later, I'll use myself. My lower back hurts. I think I've talked about in here. I have neck issues that's separate from that, but like lower back starts to hurt a bit more. And, noticed within the last couple of months that I need it to be a lot brighter to see what I'm reading on like a book. All those little things. What happens with somebody with Downs, they get all of this all at the same time. So they'll have orthopedic issues, cardiac issues, basically the same things that we all are concerned about with our own aging and the people that we care about aging, this is what's out there. And you could see, and I cut off a good part of this study here, and you have to imagine there's so much stuff here. And I asked the question, what's missing? Anyone want to throw something in the chat? Is there anything missing? I'll get to the dementia in a second here that's on here, I think. Is there anything else that might be missing that you could think of? I'm counting to my head to 5. If anyone has anything, put it out there. And I'll talk about dementia before and give you time to throw it out there if you have any idea. The big one that's missing from here. But I'll tell you, with dementia is another really tough situation for people with Down syndrome, and an important one for you. If you see somebody in your clinic, your shelter, wherever, in an MRC setting, the statistics I'm going to tell you are important for you to know. Did I write it down here? No, I did. We'll get to it in a second. All right. So what's missing from this? Mental health. There's nothing in here about mental health other than autism being on there because this is for family physicians. So family practice physicians did this gigantic study, and they talked about all these different facets of life that they needed to bring forward in this conversation, in this study. And they forgot about an entire world known as mental health. And we've talked about dual diagnosis in here, where people have multiple disorders. So that's something to think about. And here are your statistics. Odds ratios are somebody with Down syndrome also having the specific diagnosis compared to the other side of people with having the same diagnosis, it being a lot smaller compared to the regular population. So mood disorder, depression are very high. So that's, if you need to think in your head, it's like 3.5 times the general population. It's not quite the same statistic, but it's kind of in the ballpark. 1.25 times the amount of depression, 20 times on obsessive compulsive disorder. So you could see there is a lot of stuff that goes into this. Personality disorder, which is a really interesting case where somebody's personality itself has pathology. I had a patient once who came off as if he were depressed. And this isn't the guy you may have heard me talk about before that was suicidal. This gentleman was a guy who lived in a supported apartment. So he was probably borderline intellectual functioning. So not quite intellectually disabled, but close enough that he had difficulties getting a job, things like that. The job he wanted, not a job, but the job he was looking for. And I remember him manipulating me. I was younger and he liked the attention and I liked the ability. I had a lot of different clients at the time. I was doing house visits, and there were some clients where the person didn't communicate verbally. So traditional therapy, which is what I'm originally trained in, wasn't something that could be done. So, clinicians have some bias too. And this is something I could clearly see I had, spend time with, the people that couldn't talk. But when I would have a client that could talk back and conversationally, I would absolutely give them a full session whatever I could. It was good for everybody. And I remember him really enjoying these things. And again, it's not an office. I can't kick him out. I have to leave his apartment. And there's a lot that goes on when you're dealing with somebody in their own home or in a shelter where food might be involved, or sitting on somebody's couch. Somebody in that situation is out of the norm, right? And I remember him manipulating me, trying to get me to stay later and longer. He wanted me to have dinner with him. He wanted me to be his friend. And unfortunately, there's, a lack of that for people in his situation. And he was in a tough spot. He knew he had Down syndrome, which meant he told me that he knew he looked different. He knew he sounded different, and he knew that he thought differently, and that he would never have a family because of this and all these other, pretty depressive things in hindsight. And we got him, social calendar and lots of things. We hooked him up with some occupational coaching to try to get him where he was at. But when I saw him during that time period, he was just looking for a friend. So he would tell me that he was suicidal before I would leave or as I was leaving. or he would call me on my way home or leave me a message at the office. And as somebody that is on the neurotic side of things, and my own OCD goes off, where I'm worried about a person now, I know he might be manipulating me because he has a full diagnosis of this personality disorder called borderline personality disorder, where a big thing is manipulation. I had to have my boss, a neuropsychologist, like sit me down and be like, this is what's happening. He's getting one over on you. And, just something to keep in your minds again, that people with Down syndrome can have strong intellect. They can have really good strengths in specific areas. It's not the stereotypes that we used to think of people. I may have said it to this audience specifically. I apologize if you've heard this before. I know Sonia and Satori have heard this. I had a patient who was suicidal. I'm giving you the very, very small version of it. He was suicidal. He kept coming back to the hospital that I worked at, looking to go into the hospital. They kept ignoring him. And the big discussion at the time was Down syndrome is a protective factor against suicide. There are things in the psychiatry world that we call protective factors. An example that's out there, I haven't researched this in a long time, so do not take this as gospel. The irony of me using that phrase is being religious is considered, or was considered at a time, to be a protective factor, especially when you're talking about somebody that is of the Catholic religion. Again, I'll put it out there to the group. If anyone wants to answer why that might be a protective factor for the Catholics and Christians in the audience or in the world, I'll give you another minute to put that out there. But same thing, we think of these protective factors, and the gentleman with Down syndrome was told, well, I was told as his clinician, he's not going to hurt himself. Down syndrome, people are usually happy-go-lucky. He's trying to just stay in the hospital because he doesn't like where he's at. He was suicidal because he didn't like where he was at. The connection issue was that they just didn't believe somebody could be suicidal that had Down syndrome because of that misnomer, 15 years ago, of it being a protective factor. What is the protective factor for somebody that may be a devout Catholic that's thinking about suicide? What happens to you if you're a devout Catholic and you commit suicide? You go to hell. So it was thought of, at least at a time, that was a protective factor against somebody that was a devout Catholic that may have been suicidal. Again, a lot of these things are anecdotal and they're not based in science and can do more harm than good. That's why we provide data like this. The other interesting side of people with Down syndrome is the inverse relationship compared to others. So there's a lower likelihood of somebody having generalized anxiety disorder, panic attacks, PTSD, and then all these different substance abuse disorders and some of the bipolar disorders there too. Big common denominator with this is, frankly, anxiety. People with Down syndrome are processing their anxiety differently than everybody else that's out there. I don't know what or why, but that's something that I have personally been seeing in a lot of the research that's out there, because it goes against what logic tells you, specifically because people with Down syndrome, another reason for you to hear this in shelters, in any other congregate care settings, it's easy to become victimized, especially, you guys are in Philadelphia. You guys have a big shelter. You have a big shelter, not like my Monmouth County. You can have 30 people in a gymnasium somewhere. You guys do a shelter. It's a good chance it's going to be really big. And when things are really big, God bless the size of your MRC, but things can get missed. Things can get, side tabled, whatever. These are things to think about. People with Down syndrome and broadly people with intellectual disability are easily victimized, whether that be an abuse, a direct abuse, like sexual abuse, or being manipulated into doing things for other people. A lot of times I've actually seen people manipulated into selling drugs for gangs. They want to feel that sense of belongingness, like I said about the client that I had, but they're 15 years old. They want to have a girlfriend. They want to be the cool kid. They want to sit there and smoke a cigarette or smoke a joint. So they're easily manipulated. They do want to please in a lot of situations. So something to kind of keep your eyes out for in that situation. Substance abuse itself isn't really something that we see a lot of. So yes, mental health and physical health are very strongly present with people with Down syndrome. What I wanted to talk about with Alzheimer's specifically for the shelter, the clinic, what have you, and just for life, it is exponentially higher in people with Down syndrome. There's a lot of different theories where not Down syndrome, where Alzheimer's disease specifically and dementia in general comes from. If you don't know, dementia is the higher category, and then there are different types of dementia, one of which is Alzheimer's disease, which is what I think most of the population, identifies with. So these are some different areas. Those of you that are into bio, I never know who's going to be in an audience, so I put something in here. If anyone's a physician, nurse, neuroscience person, this is what's going on in the brain specifically. I'm gonna kind of skip past that. Talking about what I think and what most research says is there is this protein, there is an aspect of the chromosome that lives in our bodies. With Alzheimer's disease in the general population, the theory is that there is an issue with this amyloid protein that causes whatever the issue is, causes the symptoms of Alzheimer's disease. The specific chromosome that research has told us causes these issues is that 21st paired chromosome. So we have an extra copy of the chromosome that causes Alzheimer's disease, at least that's what we think it is. Because of that issue, we are seeing rates of Alzheimer's disease and dementia in people with Down syndrome that are literally off the charts. If you were to do a side-by-side comparison of the general population next to people with Down syndrome, you wouldn't even be able to see the top of it because people with Alzheimer's disease in the general population is less than 1% in the entire world. Coming back to the lifespan discussion, earlier I said 40, 45 was kind of the top of it. We've made so many breakthroughs in medicine and genetics and all sorts of areas of social determinants of health that we now know how to get that lifespan actually out to be pretty close with the general population. We're seeing people 65 to 75 is more of an adjusted lifespan. The problem with that is that accelerated aging is still happening in their 40s and 50s. So those last decades of life are really potentially tough. Throw more gasoline onto that fire. 30% of people with Down syndrome have Alzheimer's disease by the time they do reach their 50s. And if they make it to 60, it's 1 in 2. So if you see somebody subjectively to you, right, that looks elderly in the context of Down syndrome, give them that extra minute, give them that extra benefit of the doubt, give them that extra minute of attention, give them another eyeballing from across the room. Just keep an eye on them because the symptoms are very similar to the general population, but you're not going to see it coming in a 40-year-old. And that's 1 out of every 3 people once you hit 50, right? And people look a lot younger than they used to. People are dressing differently. So, you could have a 50-year-old walking around wearing a John Cena t-shirt and wearing shorts, and you're not going to realize it. So, assume that they're older than they are, is what I can tell you, because this is a problem, a big problem. The most concrete stuff I can give you tonight is on this slide. A lot of it probably isn't going to be a big surprise to you. A lot of it is about allowing what it is you're asking or telling a person to get processed, the processing time, the ability for those different parts of the brain to hear, process, understand, and provide a response, right? So using short, simple words and sentences is really helpful. As I'm talking to you guys, you're listening to me. Your brains are immediately activated as I'm talking to you out loud. Your auditory cortex, the cortex of your brain that's right here next to your ears, or otherwise known as the parietal lobe. This is an area of your brain that specifically is getting the signals from your ears and translating it into language. That's a process that takes a couple of milliseconds, but it is something that happens in our brain. So that message goes, we process it, and then wait, I got to respond. And I may have to respond with a smile, with a thumbs up, with a sad face, with a sentence, or with an action. All of those different choices are different areas of the brain that require your brain to do certain things. And when your brain has some developmental issues that are artifacts that are still there, there's going to be some slowing down. and it's palatable, and you can feel it. Um, so give that person some extra time. Ask very specific questions. The last thing you ever want to do is like, oh, and they actually have it here, like somebody that has Down syndrome, a student comes home from school. How was your day at school? For some people, it's an easy question to answer. For some, you're not going to get anything. You'll get good, right? It's almost like when you're talking to a teenager, right? They're purposely not giving you information. You got to ask, like, how was your math test on Monday, right? Or how was your algebra tutoring session? It's got to be specific so that you can eliminate as much of that noise as possible and to allow for a good response to come out, and patiently wait for it. Be mindful of your own affect, your body language. What are you saying with your own body to this person who, if they're seeing you, are already in a stressful situation? They're already out of their normal day-to-day. Even if it's a flu vaccine, that's not a normal day-to-day thing for any of us. And it's not a normal day for you to be there either. So you have to be mindful of how you're projecting yourself. I'm an anxious person when I'm in small groups. I'm a great MRC co-leader, but when we have like smaller conversations and discussions, I start to get not so good. Me being anxious can make somebody think I'm actually just unfriendly, right? Because I might be sitting there being very quiet. So it's not just about the Down syndrome people, people with Down syndrome. It's about you as the volunteer, you as the leader, or for whatever reason, making sure you are being mindful of how you are and what you are expecting out of folks. So, you might be serving them food. You might be offering them a drink. Give them specific things to answer from. If you're looking for a conversation, ask an open-ended question. If you're looking for a response, ask a one or a two or a yes or a no kind of a thing. Expect to repeat yourself a couple of times, maybe in some different ways. Don't use metaphors. Don't use any intangible types of conversations until you realize that they may be able to interact with you at that level as well. It's very possible. Plenty of people can. But when you see that the group of people, the bigger group of people that will be in congregate care settings, group homes, are more than likely going to be people that have a mild to moderate intellectual disability, so they'll probably need some of this. Turning negative statements into positive statements, instead of "don't go in the kitchen" or something like that, say, "come with me, I need your help with something." And that's actually very applicable to people with Alzheimer's disease as well. You can see there are some similarities in communicating and just understanding how people are understanding things going back and forth. Instead of saying, "do you want to go?" say, "let's go." You can see there's just a little bit of a flavor in there of motivating a person to provide a response or to interact with you. And also don't be surprised, going back to one of the previous slides, autism and Down syndrome, I think about 7% overlap. So you might have someone that visibly looks like they have Down syndrome, and they also have they could be nonverbal. They may have autism. So you might be dealing with that on top of somebody with a physical ailment and a mental health issue, right? So this isn't to intimidate or anything like that. It's just saying, by sitting here and hearing this, if you have somebody like this in front of you at some point, hopefully you'll remember some aspect of this so that that person feels cared for as well. General needs of the population. These are just some things I wanted to throw out there that you might be curious about, might want to hear more about at some other time, or just for you to think about. Guardianship versus independent medical decisions. Can somebody just show up to an MRC, COVID, or flu clinic and you give them the injection, right? If somebody is visibly walking up to you and they clearly have Down syndrome, are you able to give them the injection, right? Marriage, divorce, end of life and palliative care. So at what point is a medical decision that person's decision? It gets into guardianship and a lot of different things, but when a person ages out, they transition, right? We have a lot of different transitions in the public school world. 0 to 3 years old is early intervention, which is why getting those early screenings is so important, because it's a very quick window. From 3 to 5, unless you had early intervention and you qualify for an IEP, you may not get any services from the ages of 3 to 5. Let's say you do. You'll go to preschool for a child with a disability. That'll be your classification. And then you'll move. 18 to 21 is another transition period. Depending on what your services are, you may or may not graduate, but your entitlement is through your 21st year. And then you get into the general adulthood. And that's where things kind of go sideways because you were somebody else's dependent, but now legally you may not be. So that throws all sorts of questions. Housing, alcohol use. You know, if you go, there was a really great campaign this year for Down Syndrome Day, and it featured a young woman with Down syndrome talking about these same types of things and saying, you know, it's okay to let me go to a bar. And it shows her like going out and dancing with her friends, having a drink. And it was a very insightful, thought-provoking ad because you're sitting there like, you know what, I never thought about this. Can a person, if I'm a bartender and somebody shows up with Down syndrome, am I serving them a drink? Right? A lot of people might say no, but that's not the right answer. You know, people are entitled to the same equal rights under the same constitution that everybody else gets. This is one of the only groups of identifiable people that don't really have a lot of protections. There are some protections under ADA, but certainly not as many as other groups of identified classifications of demographics. So, you know, just putting that out there for all of you. There's a lot of different things out there. I talked about victimization when talking about the tendency to easily trust other people, especially adults in authority setting. So, you know, I say all of that to you as I kind of wrap up here. You know, when you're in these situations, people have gone through something if they're in front of you, or if they're at a health fair. Nonetheless, these are things to think about, and just again, showing up tonight and listening to something like this is a testament for you being a great volunteer and caring for every type of person that's out there. You know, it's nice to see that. It's nice to see the growth, and I appreciate you being here. I'm wrapping up kind of on time. If anyone has any questions, please feel free, but I wanted to wrap up before the 7 o'clock in case people had to go. So I'll pause and see if anyone has any questions, and if not, I will wish you all a great evening.
Thank you so much, Jason. I'm gonna look at the chat and just make sure I didn't miss any questions. But if anybody has any, and you, for whatever reason, don't want to ask now, or if anything comes to mind later, you can also feel to reach out to either Jason or myself, and we'll be happy to answer any of your questions in any way we can. Again, just echoing Jason's thank you to all of you for joining us this evening, and again, thank you, Jason, for providing this very informative training. Greatly appreciate you.
Thank you for having me. Have a good night, everybody. Hope to see you guys again soon. Take care.
Bye.